All right, well, we're at the top of the hour, so I want to welcome everyone and thank you for joining today's webinar. Our topic today is telehealth policy and where we are in that current landscape. This event is being recorded as well as it qualifies for a CHE credit. The credit survey and a link to where this recording will be posted will be sent in an email following the completion of the webinar today. I'm Kim Mayo. I'm the Telehealth Manager with the National Rural Health Resource Center, who is providing today's webinar. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. And to unmute your line, you can select the microphone icon in the lower left corner of your screen. If you have dialed in from a phone, you can press *6 to unmute your line. You can also communicate through that chat box, which is located also in that bottom ribbon towards the middle of your screen. If you haven't already, please take that moment to type your name, title, and organization in the chat box. That just lets us know who's joining today and lets us have a good feel of who is in the audience for today's webinar. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the technical assistance provider for the Delta Region Community Health Systems Development Program. And the Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. And you can learn more about that, our commitment on our website. As I introduce today's speaker, Caleb is going to pull up some polling questions that will help us measure our knowledge gained on today's webinar. Mei Wei Kwong, JD, has a decade of experience in state and federal policy work. She is currently the executive director for the Center for Connected Health Policy, the federally designated National Telehealth Policy Resource Center. She has written numerous policy briefs, crafted state legislation, and led several coalition efforts on a variety of issues. Ms. Kwong has published several articles on telehealth and telehealth policy in various peer-reviewed journals and is the co-author of CCHP's 50-state Medicaid telehealth reimbursement survey. She is recognized as an expert on telehealth policy and has been consulted by state and federal lawmakers on telehealth legislation and policy. So it truly is my honor to introduce Mei. And you can have the floor now. So thank you so much for being here.
Thank you, Kim, and thank you for having me here today. As Kim said, my name is Mei Kwong. I'm the Executive Director at the Center for Connected Health Policy. And before we get started, I always have to do this, a couple of quick disclaimers. Know that any information that I provide in today's talk should not be considered legal advice. It is strictly for informational and educational purposes. If you are interested in a formal legal opinion, please consult with legal counsel. And also, if I happen to mention a company or show a picture of a product or mention a product, know that neither I nor CCHP has any type of relevant financial interest, arrangement, or relationship with such a company. A little bit of background about CCHP. We were actually established in 2009 as a California telehealth policy organization. We're a program underneath the Public Health Institute. However, an opportunity became available in 2012 to be the National Telehealth Policy Resource Center through funding from HRSA. CCHP applied for that, and we got that funding, and we've actually been serving in that capacity ever since. So well over a decade of doing this telehealth policy work on a national scale. We also work with a variety of other funders and partners on the state and federal level on more specific projects related to telehealth or connected health. And CCHP also acts as the administrator for the National Consortium of Telehealth Resource Centers. For those who are not familiar, there are actually 14 telehealth resource centers, all funded underneath the same funding stream that CCHP gets our funding from. The other 13, there are 12 regional resource centers, and they cover specific states, and they do more of the program operational questions and TA. They can do some policy work, but when they run into policy or technology questions that they can't answer, they elevate it to the national organization. So CCHP is the policy one, and there's also a national organization based in Alaska that focuses in on technology. So I encourage you to reach out to your regional telehealth resource center if you have questions related to telehealth, but really you can reach out to any of us and we will make sure that it gets to the appropriate telehealth resource center. So the National Consortium of Telehealth Resource Center is really just all 14 of us working collaboratively together. A couple of years ago, we realized that we may be duplicating efforts because there are certain things that can cross multiple regions or be applicable nationally, certain resources we are creating. So we decided to allocate a little bit of our funding to work on these collaborative projects together. And that was underneath the umbrella of the National Consortium of Telehealth Resource Centers. And CCHP was selected to act as the administrator for that group. We also at CCHP convene a group in California called the California Telehealth Policy Coalition that has over 170 statewide and national groups who are interested in specifically in California telehealth policy. So we also keep abreast of what's going on a little bit more deeply in California, and also they work on suggesting of legislation and working with the Department of Healthcare Services that oversees the Medicaid program in California as well too. So for today's webinar, I was asked to really provide you an overview of what's going on the federal and state level telehealth policy landscape, and also to talk about the current status of some of these policies and what items that you should really keep your eye on and what might happen this year, and also do a little bit more sort of future forecasting a little bit out beyond this year. I will say that this webinar is going to be fairly high level. You can get pretty deep into telehealth policy and can get pretty complicated. So we're going to approach this maybe not at like 30,000 feet, but we're kind of high up there. So we're maybe more around the 20,000 foot level here. So this is not a webinar to answer your specific billing questions, such as, you know, I have a patient that came in, we treated them for this through video and everything, and they're a Medicare patient. What do I put on like line 32 on the 1500 form? So we're not going to get into that nitty gritty, but we will talk about like the overview policy and how that's impacting the use of telehealth. So I've split this up into federal and state, and underneath those two sections, there are subsections of the topics that we're going to be covering. So for federal, we'll be covering Medicare, and that's CMS's policy, the prescribing controlled substances, HIPAA and privacy, and licensure. And then on the state side, we'll be talking about Medicaid, private payer, prescribing, and licensure. As you can see, like very similar topics, but they have very different policies regarding these different topics here. So while like the general topics similar, like Medicare, Medicaid, that's around reimbursement, prescribing, and also licensure, there's going to be very much different types of policies underneath those topic headings. And also note, as I said, this is going to be fairly broad because we can talk for hours about telehealth policy and really get down to the nitty gritty. But note that these are not all of the policy areas related to telehealth. For example, there are a lot of sort of almost subcategories underneath these general categories. Consent, for example, is often mentioned underneath Medicare or Medicaid policies, or it may have its own separate section in a state law or regulations here. So really, there's like a lot of areas which telehealth policy touches upon. It is healthcare. So think of all of the different areas of healthcare policy. Likely there's going to be something related to telehealth, or telehealth will, you know, have some sort of influence on it, or it would be influenced by that particular area as well too. So, but these are generally like the major categories of where existing telehealth policy is, and that's policy that specifically says something about telehealth. So that is why we're covering these. And these are also sort of high impact policy areas, which is another reason why to cover them. So to understand telehealth policy, you have to understand there's 4 sort of major streams or 4 major channels in which it builds the telehealth policy itself. So most folks are familiar with like laws and regulations. So Congress or state legislature passes a law. It's implemented through regulations. A lot of folks are familiar with, okay, I understand that as policy, but also keep in mind there's two other areas that influence how telehealth can be used and that builds telehealth policy. And those are guidances and court cases. Now, guidances are kind of those not quite law, not quite regulation things that an administering agency might issue. So such things such as a provider manual that, let's say, a Medicaid program issues, or maybe like a letter to providers from a Medicaid program saying like, this is how we're going to do X, Y, and Z now. So they do an interpretation. They're really kind of interpreting what the laws and regulations are saying, because there may not be clear, or, there's nothing specific in there applying to a specific situation. So those are what guidances are. And they can come from the administrative agency. That's usually where they come from, but also keep in mind, they may come from something like a medical board, a licensing board as well. They may be giving guidances as well to their licensees. So those are important to keep an eye on as well. Then you have court cases. Now, court cases, this is, I think, a little less sort of like on people's radar sometimes, but they too can influence the development of telehealth policy or policy in general. Because let's say, for example, a law is passed in a state, and we'll get into like a more concrete example later on in the presentation, that somebody says is, illegal or it's unconstitutional. And then, the court will decide on that, and that can shape like policy as well, depending on how the decision goes. So these are four sort of your major areas that really influence the development and shaping of policy in general and telehealth policy. We'll first start off with the federal level and CMS and Medicare. And CMS and Medicare policy around telehealth is really on the federal level, the section or the area of policy where you have the most telehealth specific policy on the federal level. So this is sort of what gets the most attention in a lot of ways. And it's also the one that most people are familiar with, but it's also the area that's probably the most developed for telehealth, specific for telehealth, as opposed to like some of the other things that we touch upon, or some of the other areas that we're not talking about today, may not have really gone down for that path and having a telehealth specific policy. But CMS has had one for several decades now at this point. So it is fairly developed, and it is fairly detailed in a lot of ways. So what we had with Medicare telehealth policy and its evolution is that it can be divided up into really three eras. You have the pre-COVID era, you have what happened during the pandemic, and then you have post-pandemic, which is what we're in right now. Pre-COVID was fairly limited. During the pandemic, they opened it up. So they temporarily like eased those restrictions that kept it very limited. And then post-pandemic, we're in kind of like this very strange sort of holding pattern, in that we had a lot of what they allowed during the pandemic still going on at least till the end of this year. Now, to understand the telehealth policy, reimbursement policy, and coverage policy, you have to understand that there are four issue areas that really make up how that policy is built. So these are sort of issue areas that the policy would typically touch upon when you're talking about reimbursement policy. And this is true also for Medicaid and private payers as well. So this is just how it's kind of like shaped up. So you might have a policy that touches on one or more of these issue areas. So service, location, modality, and provider. So say, for example, you have a state Medicaid program that says, this Medicaid program will reimburse for mental and behavioral health services, so the services that are involved, when the patient is located in a doctor's office or a clinic or a hospital, the location of the patient, and when the service is being provided via live video, the modality that's used, and when the provider providing that telehealth service is a psychiatrist or a licensed social worker, the type of provider. And you'll see like the reimbursement policy, whether you're talking about Medicare or Medicaid and like sometimes commercial payer, it's built around these four issue areas. So they may have something related to one or more of these, and that's how they can, how expansive they can make their policy, or how like narrow they can make their policies. Medicare is a little bit trickier in that they also have this other area of technology-based services called communications technology-based services, which uses telehealth technology to deliver those services, but CMS does not regard them as telehealth services. So what's the difference? It's like those communications technology-based services, CTBS, use telehealth technologies to provide these services, but there's no in-person equivalent. So a telehealth service would have an in-person equivalent. So for example, let's say I go into my doctor's office for a visit. I can do that in person. I can also do that via telehealth. However, let's say my doctor wants to monitor my blood pressure because I'm suspected of having hypertension, or I do have hypertension, and they want to do readings for a full week. So I'm not going into my doctor's office every day, multiple times that full week, getting a blood pressure reading, but I can do that via technology at home and have those readings sent to my doctor's office. So that's like a non-person equivalent, that remote monitoring of me taking blood pressure. And CMS said, you know what? Technology is allowing us to do some of these services we don't typically do in person, but we can do them via technology. They're pretty good. We think they have some benefit here. We're going to pay for them. However, because telehealth is this one-to-one replacement for something in person, it now falls into this other category called CTBS. So CTBS, the reason I'm explaining all this is because when you look at Medicare and technology delivered services, they have two distinct categories. The telehealth services has a whole bunch of restrictions on it because it's embedded in federal law that they have these restrictions. So limitations such as, what type of provider can provide the services, what type of modality is used, where the patient's located, all of like these 4 issue areas I talked about. CTBS for Medicare, because they don't regard it as telehealth, they don't have those restrictions technically. They don't face those telehealth statutory restrictions like telehealth does, because it's this different category. CMS is saying this is not telehealth. It's using telehealth to provide those technologies, but Medicare is saying, no, in our eyes, it's not telehealth, so we're not held to those restrictions in federal law. So we can create our own restrictions, and they do, but those federal statutory restrictions don't apply to CTBS. So the reason I'm explaining this, taking so long to explain this, is because this is a distinct Medicare policy. States are a whole other different story. They may or may not follow what CMS does, partially because some of the states were already reimbursing for some of these services long before Medicare CMS came up with this sort of like policy here around these services. So that's where it can get very confusing. And it definitely got confusing during the pandemic because people were conflating telehealth policy and CTBS policy as one underneath telehealth when they were talking about Medicare. And we were getting calls saying like, wait, why am I getting reimbursed so low? And it's like, well, how are you coding it? And when they would give me the code numbers, like, that's CTBS. So CMS will treat it differently. Your policies that you're focusing on were their telehealth policies, but they don't view that service as telehealth. So that's why you need to make this distinction. It is extremely confusing. And I don't know if like everyone got my explanation. And then it gets more confusing when you go down to the state level and you start looking at Medicaid programs, and the commercial payers sometimes might be a whole other story as well too. But this is like kind of the state of like the telehealth reimbursement policy, 2 different buckets, CTBS and then telehealth. I'm not going to really focus in on like CTBS because the temporary policies that we have now left over from the pandemic that have been extended are really focused in on those telehealth policies for the most part. Now, this is sort of just, again, a high level overview of like the stages of telehealth policy and what could happen. So pre-COVID-19, as I mentioned earlier, there were limits on patient location, both geographically and by site. So underneath what I will call what is pre-COVID policy, telehealth policy in Medicare, and is right now still our permanent policy. So it is the policy that will stick around unless somebody changes something once the temporary policies have expired. There were limits on where the patient had to be in order for that service to be eligible to be reimbursed by Medicare. So the patient had to be in a specific location, both geographically and by site. And geographically was a specific rule definition. So, for example, it was like so narrow, a lot of the parts of California where I'm based would not qualify underneath like the permanent policy. And the patient, for the most part, had to be in a specific site, usually some type of healthcare facility site, hospital, doctor's office, clinic. Very narrow exceptions for the home. So they were very limited exceptions for the home. So in most part, you had to be in a healthcare setting type of facility in order for that, the patient had to be in order for that visit to like qualify for reimbursement. There was also a limited list of eligible providers who could provide the services via telehealth and get reimbursed. People who are not on that list or entities not on that list were FQHCs and rural health centers, PTs, OTs, very small, short and narrow. The limit on the modality. So essentially it was live video. You could do some store and forward, the asynchronous version in telehealth if you were in basically Hawaii or Alaska. So very limited on what that is. And then there was a limit on services. The services, there is a little bit more wiggle room for CMS to decide that, but it was like a much more narrow list before the pandemic. During the pandemic, all those limitations that I talked about, for the most part, were temporarily lifted. So CMS said patient can be anywhere, both geographically, and site-wise, like they didn't have to be in a clinical setting. They could be at home, they could be at work, they could be at school. They also expanded the list of providers. They allowed FQHCs and RHCs. They basically said any Medicare eligible provider who could provide these services could do this via telehealth. They allowed some services to be delivered via audio only. So they expanded the modality as well. They didn't expand the asynchronous one, but they expanded the modality, the audio only, allowed audio only to be used to provide some services. And they also expanded the eligible services list. Again, that last point about the services, CMS does have a little bit more control over that. They don't necessarily have to wait for Congress to do most of that. They kind of oversee that for the most part. But the other three, if they want to change the other three, CMS is very limited in what they can do. They would need Congress to act. So what does the future look like if nothing happens now? Like, right now services are temporarily allowed. The waivers are temporarily in place until the end of 2024. If nobody does anything else, Congress doesn't do anything else, the CMS doesn't do anything else, and nobody does anything else, what will it look like? We basically revert back to the pre-COVID Medicare permanent policy. The only things that are different than what happened, to a 2019 Medicare telehealth policy to January 1st, 2025, if nothing else happens, is that now mental health services, their location limitations are being lifted because Congress did pass something back in 2020 where they said that the geographic and the site location limitations would not apply to provision of mental health services via telehealth if certain conditions are met. And that certain condition was that there needed to be a prior in-person visit with the telehealth provider and the patient before the telehealth services could take place. So that it was great that they lifted the restrictions, but that sort of caveat of like needing that prior in-person visit with the telehealth provider kind of really narrows things down a little bit too. And then they also are allowing audio only to be used to provide mental and behavioral health services, some of them as well too, but they also have like caveats on it if certain conditions are met. So that's kind of where we are today as far as we know what the policy is and what the future may look like if nothing changes between now and the end of the year. So where are we now? As I said, they waived the geographic requirement. They are still continuing to allow FQHCs and RHCs to be temp providers. They're allowing some services to be audio only. They expanded the eligible service list to be provided via telehealth. That last point, for the most part, a lot of that is permanent, but everything else is temporary. This is just until the end of this year. Some of the more sort of, subcategories or nitty-gritty policies that impact the use of telehealth and where their status is still again on a temporary kind of hold here. So for example, waiving the frequency limit on telehealth visits and SNPs, it used to be once every 30 days you can do that. And then CMS changed their policy, I think in like 2021 or 2022, where they said like, well, you can do it like once every 14 days, which was better. But during like this temporary holding period, this temporary waiver period until the end of the year, they said like, we're just going to waive the frequency limit. So there's no limit on it now. But again, if the policy doesn't change, we revert to the once every 14 days, I think is how it goes. Allowing providers to use a business address. Now, this is something that has changed. This is only happened a couple of weeks ago. So when you become a Medicare enrolled provider, you obviously provide like an address where they can reach you. And also you know like where your principal business is. And the thing is with telehealth is that a lot of people may be doing their business out of their home. So they put their home address down as like their place of business. Unfortunately, there are times where that information can be accessible publicly, just because of like data information and how that's shared. And so that concerned a lot of telehealth providers saying, well, that's actually my personal home address. So that's actually been kind of an issue for telehealth over the years of like, well, we're hesitant to become a telehealth provider underneath Medicare because my home address might be put there. And I don't have an office address. My entire practice is out of my home. So CMS had temporarily like suspended that policy. They said like you can use a PO box during like the pandemic, and they extended it during like this temporary grace period phase. But now they've like used it. Now they've solidified a permanent policies. And this is actually just recent where they said that, okay, if you are an individual provider, like a solo practitioner, an individual provider, you list yourself as an entity one, classified as an entity one, as a Medicare enrolled provider, you can use your U.S. Postal Service PO box or a commercially provided PO box, like, you know, a mailbox accept type mailbox. So you can use that address, and that's the address that I'll be seen publicly. So you'll be protected, everything, et cetera, et cetera. So that's like one of those policies that they didn't have to wait necessarily for Congress to find a solution for, that CMS like found a solution for themselves, or they had that power to do that. And that's an example of like things to like keep your eye on throughout the year. It's like these sort of like sub policies or subcategory policies that you don't necessarily need Congress to act, but because they are guidances or they're administrative policies, the administrating agency can like act on, that can have like an impact on like the usage of telehealth as well. And they can come like throughout the year too. So that's one thing to be aware of. What I have here, and I do believe you will have access to a PowerPoint, are like different links that you can like dive a little bit more deeper on. As I said, this is like a high level overview. I just want to highlight a couple of like important things that are going on and questions that are still like unanswered at this point. Prescribing controlled substances. So very roughly, the way prescribing when you use telehealth, the way the policy works is that the feds control prescribing of controlled substances, states oversee prescribing of everything else. So federal law, prescribing controlled substances when you're talking about telehealth, states, it's everything else that are not controlled substances that they have control over. And what we have for prescribing controlled substances via telehealth, sort of like that history, is there are limited exceptions on using telehealth to prescribe a controlled substance. It was put into federal law underneath something called the Ryan-Haight Act, which when you talk to telehealth people and they're talking about prescribing, they may sometimes use the shorthand of Ryan-Haight. That's because where that telehealth section of law came in to be was underneath the Ryan-Haight Act. And what they do is there's like a list of very narrow exceptions in how you can use telehealth to prescribe a controlled substance without that telehealth provider having done or conducted an in-person exam of the patient. And these exceptions are some things, basically the patient has to be located somewhere, such as a DEA registered facility or with a DEA licensed provider. They have to be like, located somewhere that, they could get to someone or someone's there to like assist them when that telehealth interaction took place. One of the exceptions also was when a public health emergency is declared. So a lot of people may have been confused by this. They may have thought like, oh, when the public health emergency was declared, Congress passed a law to allow prescribing a telehealth without falling into one of those narrow exceptions or having an in-person exam. It's like, no, that exception was always in federal law. That's why when the public health emergency was ending, you never saw Congress act on anything. It's because it was just an automatic trigger that happened in federal law, and they left it up to the DEA to decide what they were going to do. So what the DEA was deciding last year before the public health emergency ended was they said, okay, they issued proposed regulations that this is how we're dealing with the post-PHE world and prescribing controlled substances. And what they did was just create another narrow exception. So I'm not going to go into what that narrow exception is. You can always, look at some of the CCHP material, but it was not met kindly by the general public in the telehealth field. It was like a narrow exception. They only gave people 30 days to respond to it, and it would like go into effect pretty quickly. But in those 30 days that they gave people to respond to it, because they have to give time for people to comment publicly, they received nearly 38,000 comments. So when you have like these proposed regulation process, you're supposed to allow the public time to give comments, and the administrating agency must respond to all those comments. There was no way they were going to be able to respond to 38,000 comments. And this was taking place, like they issued the regulations March 1st. They gave people until like essentially April 1st to respond. And then the public health emergency was ending May 11th. There was no way they were going to be able to respond in 6 weeks to 38,000 comments, which they were legally obligated to. So what they did was they said, okay, you know what? We're just going to extend the PHE situation, like allowing the temporary waiver. At first they said November 2023, and then like during 2023 there were all these movements that led them to say we're going to extend it until the end of 2024. So basically aligning up with what was happening with Medicare and their temporary waivers. So they said we're going to extend it out to there and then decide what we're going to do. So right now we're in a holding pattern. We're not quite sure what they're going to do. January 31st, however, now this was already in the process. So this has been kind of separate of like what's going on with the DEA and all this. January 31st this year, though, final rules were finalized for the prescribing of buprenorphine, which is used to treat opioid use disorder, prescribing of buprenorphine by an opioid treatment program, and you're using telehealth. So we do have like an understanding of at least this small section of policy here. It's like if you're an opioid treatment program, you can prescribe buprenorphine using telehealth without that in-person visit or without that, those narrow exceptions. And also you can do it via audio only as well too. So this is permanent policy. And this was finalized in 2024, but it's very specific. Again, it's just for an opioid treatment program. The DEA policy is wider, and also it's not limited at this point right now to buprenorphine. So that's something to keep your eye on. People have asked me what I thought when they may do something. I would think they would have to do something soon just to avoid like the 38,000 comments possibly happening again and like winding up with like not having enough time to respond to them. That would be my guess, is that they would do something soon and give themselves enough time just in case they got like a flood of comments here. But so far I haven't seen anything released yet. So that's another area of outstanding policy as well too. HIPAA privacy and data. Pre-COVID-19, really nothing about telehealth in HIPAA. So telehealth providers still had to make sure they meet HIPAA requirements, but there was nothing in HIPAA specific to telehealth. So telehealth providers just had to figure out, like how can I make sure that when I'm doing telehealth, I'm not violating HIPAA in any way. Post-COVID-19, realization by policymakers of like, yeah, there's really nothing in there about telehealth. Maybe we should do something about that. So what they have done is that, and this is where the guidance comes in. There were a lot of guidance being issued by the Office of Civil Rights that oversees HIPAA and saying like, these are our suggestions around HIPAA and like what you should be doing with it. During the pandemic, they like basically, again, issued a temporary sort of like, we're not going to like really ding you on HIPAA things and telehealth during the pandemic. However, when the PHE is over, that went away immediately. So the Biden administration did issue an executive order to look at updating HIPAA. I have heard that there may be something by the summer regarding that of this year, but that's about it. I haven't seen anything definite come out. There's also been a lot of resources that have been issued by different agencies saying like, these are our guides, again, the guidance again on like how you should like approach using telehealth or audio only when you're talking about, protecting patient information. Now, the reason I want to bring this up and I want to stress how important this is, privacy and data, is because it is on a lot of people's radar, especially federal policymakers, because there have been multiple times over the last couple of months where the FTC and OCR have like stressed again, saying like, it's important to figure to how you handle that patient health information. They have actually dinged telehealth companies for not protecting the data or for maybe like sharing it with more marketing purposes. Expect this to be ramped up because of the Change Healthcare cyber attack. You've all heard about that. They were hacked. They screwed up United Health. They disrupted the pharmacies. They're still trying to like clean up that mess right now still. That's even, I mean, all those previous bullet points I had up there were said, oh, they're really looking into this. So I'd be careful about that. It's now ramped up even higher because of this Change Healthcare attack here. So I warn folks who are using telehealth, particularly providers, and like, be mindful of that. Understand like, how the information is being transmitted. Like if you're using somebody else's platform, is there something in there that says that they're gathering data and they can sell it or market it in some ways? Just be mindful of that. I haven't necessarily seen them go after like an individual solo practitioner, but they have gone after telehealth companies who have been providing services here. So again, just be mindful of all this information, keep abreast of like what's going on. I think this is going to be like a really big sort of policy development area that's going to have significant importance. A lot of it because of like what's just going on around it, such as the Change Healthcare cyber attack. Licensure. For those of you who are familiar with it, licensure is actually a state issue. The states control that. The feds don't have any say over licensure. And all the states say essentially is, if you're going to practice within our borders, you got to have a license that we issue as a medical provider. So you need a doctor's license, you need a nurse's license, whoever's like, whatever your profession is, you're going to need to be licensed in our state. Why do I have this in the federal section? The reason I have this in the federal section is because December 2023, a court case was filed in the New Jersey District Court where the plaintiffs have said, you know what, the New Jersey telemedicine licensure laws violate the Constitution. So this is now a federal issue here because somebody has brought up in federal court that licensure laws possibly violate the US Constitution. So the case is McDonald versus New Jersey Board of Medical Examiners. It's Sabano, I think, is like the name that's on the case, because I guess he's the leader or executive director or something of the medical board. So they need a person's name on there. And basically they're saying that the licensure laws are illegal because they violate the US Constitution, and they base their arguments on those 4 parts of the Constitution there. And the thing is that the New Jersey licensure laws are very similar to like all other states' licensure laws. So if this case goes the way of the plaintiffs, we could see this reverberation effect throughout the country because other state laws on this issue are very similar. And so they could be deemed unconstitutional. This case was just filed in December, so it hasn't even like necessarily gone to court. I think the defendants, the state of New Jersey, their deadline just to like have a response to the plaintiff's like initial filing was just this week. I haven't been able to like access it yet to see like exactly what they said. So this is like a long way from being settled, but it is something to definitely keep your eye on, because, and now this is where I'm saying the other element of a court case affecting policy, impacting policy has, an impact here. Depending on how this case goes, we could suddenly see like all these licensure laws be deemed unconstitutional. And that has been like a significant barrier that a lot of people have noted for telehealth, is that you need to get licensed in every single state. Long way from being decided. Like I said, it's a brand new case, December 2023. The defense just had like their deadline just expired to file. Whoever loses, I'm going to assume they're going to appeal the case, whoever loses. So it's still like on this track. So don't expect a resolution this year, but it is definitely something to keep your eye on. And also, the question is, would like the state change their laws in some way in order to avoid this court case? Because then the court case can be deemed moot if the state of New Jersey changed their law in some way to address all of these points in some ways. And then that could also have an impact throughout the country as well too. Like people might be like, oh, they brought that court case up, but it never got fully heard. Somebody might file a case in my state, but let's copy what New Jersey did because that got them out of that pickle. So there's like all these different like potential avenues that this can go down to. So definitely important to keep an eye on.
Hey Mo, can I ask
Yeah.
you a quick question on that? That's counterintuitive in some ways, because there's like that state level, like commerce clauses that make sense, like the interstate workings back and forth, but then there's also like credentialing at the state level. So this would have to be like a superseding kind of like precedent that the court would state that would basically allow credentialing, allow all of this like interstate work between different providers to occur.
Well, no, the case
Yeah.
is based specifically on the licensure law. So they did not bring up credentialing. So the court would not focus in or like say anything about the credentialing issue. It would just be focused in on that licensure law. So so that would just be a whole other thing that would need to be like addressed, or somebody would have to bring it out. The court's not going to okay, let me change that. I don't make any prediction on what courts do these days. So, but my guess would be they would just stick to what was brought up in like what was filed, and what was filed was just hyper focused in on like those licensure laws. So everything else about credentialing, everything else, see, this is the problem with policy. It's like it's all intertwined. So when you change one thing, it's like it could have all this other impact somewhere else, or you can, I see this all the time with telehealth. It's like, oh, they changed this and they allowed this, but we like a group, let's say, oh, we as a hospital can't do this because we have this regulation on me. So, how does that work? So yeah, this.
Yeah, it's a
Welcome
lot of
to policy.
effects. You're right.
Yeah, welcome to policy is this whole sort of web of things. But no, this case is hyper focused on those, is specifically focused on the licensure laws. So they would not even, my guess would be they're not going to even touch the credentialing on that, like whatever judgment they do on this. But important case, and the fact that they based it on the U.S. constitutional law and not just sort of like New Jersey Constitution is now like it's a federal case. So
right. It has some pretty big implications, though. I worked on a highly specific field within sickle cell disease, and there were providers in Washington state that wanted to help out patients in California, and they couldn't do it.
yeah.
And some of that is really, it's a challenging part of our system, having a super specialist in an area where they can't provide care to somebody who, may find it beneficial.
Yeah.
So,
and that's the case here, is that it involves two sort of rare conditions where they need a specialist to help these New Jersey residents. One of the doctors was located in Massachusetts. The other one, I think, was in Pennsylvania. So yeah. I mean, it will be interesting to watch how that goes. And then whatever they decide, the kind of like ensuing sort of situation. So Medicaid and private payer laws. So just very high level over here. Medicaid in a lot of ways in general, a lot of states were far more advanced than what Medicare was before COVID-19. But state Medicaid programs also had to make temporary waivers in response to the pandemic as well, too. Nobody was just sort of like, oh, we're ready for a pandemic because, we allow telehealth. There's no restrictions on telehealth. Everybody had to make changes. It just meant it was just a matter of like, the extent of the temporary changes they have to make. The thing with the states is, for the most part, states had already settled what their post-PHE situation is going to look like, and they settled on that like long before the federal PHE was declared over, for the most part. A couple of states are still like in a temporary holding period. They did do like an extension of their PHE policies out to a point in the future, very similar to what the feds did. Two states that come to mind are Connecticut and Maryland. They have like temporary policies still in place. But for the most part, most states said like before May 11, 2023, they said, well, this is what we're doing permanently. So, they were settled. Right now, 50 states and DC reimburse for live video, something for live video. I mean, it could be like fairly narrow, like just mental health services, or it could be like, it's just basically everything. And then 33 states reimburse for some sort of forward. Now, this is where CTVS gets a little like confusing here. So they may only do it for like communication technology-based services, where they say like, these are the codes that will reimburse. And so they don't count it as storm forward. This is where it starts getting like a little bit murky, that CTVS that I talked about earlier in the Medicaid programs. Some treat it just as telehealth. Others treat it as its separate entity, similar to like what Medicare does. 37 states reimburse for remote patient monitoring. This is the most interesting thing. 43 states reimburse for some audio only. If you had asked me pre-pandemic, how many states reimburse for audio only, I said they don't, because most states don't regard that as part of telehealth. This has been like a seismic shift here in telehealth policy, a significant shift. This is a new development where it now comes underneath the umbrella of telehealth. And 43 states reimburse for something. A lot of it is usually mental behavioral health services, but they're doing something now that this was like a policy that did not exist pre-COVID-19. Wasn't on anybody's radar to do. I mean, if you had asked telehealth folks, they said like, that's not part of telehealth. It's now part of telehealth. And then 43 states in DC and the Virgin Islands have some sort of private payer telehealth law. Now, these laws vary in what they do as well, too. So you're going to have to look at your specific state to understand what they're doing. They can be everything from a private payer law that says, well, health plan, you can reimburse for telehealth delivered services if you want to. So no mandate on there. I think that's Florida. All the way to like a state saying, you know what, health plans, you shall reimburse for telehealth delivered services. And by the way, you will reimburse them the same way you would have had that service taken place in person. So parity of coverage and parity in payment. And then all the other states kind of fall in somewhere in between. So you got to really look at the state and how they crafted their law to see like the extent of their coverage and their reimbursement. Let's take a deeper dive. Caleb did provide for me like, where most states people are from. So Medicaid audio only policy, for the most part, all of your Medicaid audio only policies do reimburse for that, except for one. I think that's, sorry, my geography, I think that's Mississippi. So you reimburse for something delivered via audio only that we were able to find, like within like the Medicaid policies that we were able to like access. So there's something there that you were among those that made the changes like during the last couple of years. Not all policies are created equal though. So these are the audio only policies for the states and how they've written them. And as you can see here, it says Illinois, it's a fairly broad policy. It says kind of like, you know what, as long as it kind of meets what the service is, you can do it via audio only. But you look at Louisiana and what the audio only or phone call policies that we found were very specific as to who can do them though. So this goes back to my, building of reimbursement policies of like those 4 issue areas of location, provider, service, and modality that's used. Here's something where they're saying, well, social workers can do this and rural health centers, federally qualified health centers can do this. And those were the policies found. We didn't necessarily find for Louisiana like that broad policy that you see there for Illinois. So while they can have, we can say like, yes, they have audio only policies, you got to dive deeper in there because there may be more details that surround it that create these limitations or not. And sometimes having a broad policy like Illinois can be kind of not great too, because it's so broad, there's like not enough details for you to maybe figure out what you can or can't do. Sometimes providers can be very risk averse. They're like, well, but I'm not quite sure because there's just not enough details to like direct me here. State and prescribing. I mentioned earlier, controlled substances, federal level, everything else is on the state level. And a lot of times in how they craft their telehealth policies for prescribing is really starting at the beginning on like how that patient provider relationship is established. So they say that the relationship can be established via telehealth, but it depends on the type of modality of telehealth. Usually live video is like all that people will allow. There are a couple of states that allow you to establish this asynchronously, but that's kind of few and far between. Your sort of like safest option is via live video. But they can also do limitations on prescribing. And what we've seen are policies around limiting using the telehealth to prescribe when an abortion-inducing drug is involved, when it's vision and hearing, when you're prescribing those types of devices, marijuana, and controlled substances. A lot of times they'll just say like, you got to abide by federal law there too. So the example there I have is from Tennessee, where they're talking about like optometrists and prescribing and how telehealth is used in that way. So you can see like there's these, while they may not be focusing on controlled substances necessarily, there are pockets of health services where they may create like limitations on how you prescribe. Licensure. Federal court case aside, the states do control like licensure and like basically require that you need a license in their state in order to provide services. The way to make exceptions for that, the most popular way has been through compacts. Now, compacts are agreements between state and like, we will address this particular issue in this way. And for licensure, there are a multitude of licensure compacts out there, and they are specific by profession. So they will say there's a medical licensure compact for physicians, there's a nurse compact, there's a PT compact, there's an OT compact, there's a social worker compact, there's a psychologist compact, and et cetera, et cetera. And each compact is differently structured. So you can have a compact that says essentially, you can have one license from a compact member state and you can practice in like all the other states, no problem. Or you can have a compact that says you can have a license from one compact member state and you can go through an expedited process to get a license in another compact member state. The latter is what the physician licensure compact is. The one license practice in multiple state, an example of that is the nurse licensure compact. So depending on what profession you are, you might have a different process. Keep in mind, there is no licensure compact where all 50 states in the District of Columbia are members of. So that does not mean this gives you like ability to practice in every state if you have like a certain compact license or something. No, because there is not a single compact everybody's licensed in, or everybody has agreed to be in all the states. And I would say like, some of the ones that are bigger, the bigger ones, like the physician licensure compact and the nurse licensure compact, we're seeing less legislation being introduced to join those compacts. So they may have maxed out. So there are going to be holdout states for some of these compacts, just no matter what happens. California is not a member of any licensure compact state. The other option, and I thought this would take off more, but it actually hasn't. So this has just been kind of restricted to like Florida and one other state, are registries where you can get on this registry and apparently they think you're a good actor, so you don't have to get a license. Less popular. I thought there would be more of that, but there hasn't really been any movement on. What we are seeing are limited exceptions. So limited exceptions are certain scenarios where they say you don't have to get a license in our state. And there's such things as you had a prior established relationship with that provider, or you are only providing services to our state infrequently, or you're like right on the border of like our state. So these are like limited exceptions that states have carved out for providers. Again, I put another example there. It's for social worker this time, and it's out of Kentucky of like, a temporary permit holder that they're allowing for telehealth. So what to look out for, and we are coming to the end here, what to look out for 2024. So it's really like the temporary policies. What's going to happen with them? Is something going to like change? What are we going to see? Or are they just going to like, abruptly end starting, at 11:59 on December 31st, 2024? What happens with there? Where they can see this, I don't see this as being like in a federal bill, like a federal standalone bill. My guess is they'll weave it into like larger bill. That historically what they've done, that's historically what they've done in the past. And a lot of times it's been in an appropriation bill, in a budget bill. So you got to keep your eye out on those larger bills. I have heard that they may consider another temporary extension, like another, say like a year grace period. We are in an election year, so they may not want to make a final decision during the election year. So they could just extend this out for like, oh, we'll do another year or two, gather more data, that type of thing. HIPAA, privacy and security, protecting personal information. I think all that's going to be very important this year. Keep your eye on it. AI, I have not spoken to AI, but that's like on a lot of their people's radar. There have been sort of like, executive orders and like guidances, again, draft guidances on like, how to approach AI, something to definitely keep an eye on. And then broadband, the Affordable Connectivity Program, that's actually winding down because they don't have a budget passed and there's like no continuous funding for it. So they're actually winding down. For those who aren't familiar with that, that gave a little stipend to low income folks in order to pay for their connectivity and broadband. It is popular. So I'm assuming like once they get some of the budget stuff worked out, there may be an extension of that as well too. But basically they've run out of money at this point. States said most of them have settled on their policies, but what we are seeing on the state level is a lot more interest of like, let's gather the evidence of this working. We want some more data on like if these Medicaid policies are working here and the impact of them. So keep in mind, a lot of states are like digging more into research and evaluation. Where we are going to see some areas of further expansion, probably, maybe not. I think licensure and prescribing probably would be the main issues. I'm a little less certain that we'll see changes to the Medicaid programs, only because a lot of states are facing budget shortfalls. So you start expanding like Medicaid programs and like allowing more services to be allowed, they're going to see that as like a cost to the state. And if they're a state facing a budget shortfall, they're probably not going to want to do that. So, but it's something to keep your eye on as well too. This is our website. We also have a newsletter as well. I know I ran on for a long time here, but there was a lot of stuff to cover. And as I said, this was high level as well too. So there's still a lot more to cover, but I've got a couple of minutes to take questions.
Thank you so much, May. That was great. Yes, if you have any questions, please come off mute, put those in the chat. We do have in the chat, I do see one thing regarding Louisiana Medicaid does not allow audio only for medical. They will allow for behavior.
Yep. And that's where, again, where I go into like those 4 areas on where they can like limit the policy as well too. So they're limiting it to like the type of services that they're allowing it to be reimbursed for. Not surprised. And be quite frankly, they're not alone there. A lot of the audio only policies that we see in Medicaid programs, a lot of that have limited it to just behavioral mental health services.
Any other questions out there? We do have just a few moments. If you do, it's a great information, lots of information.
Yeah, I'll chip one in, just a kind of a comment based on what you were talking about with it, HIPAA. HIPAA is going to, as far as HIPAA regulations, a lot of our platform use, really, there's not a whole lot of protected health information that goes into the platforms. Moreover, most people default to use their EHRs as the backbone of their own clinical review. But AI might change that. It might change it significantly because it's going to be processing all that information. So my guess is within the next 5 years or so, especially like AI triage systems, any kind of intake process, it's going to be pulling that patient level data, whether or not it's, connected to an EHR. And so that is going to be tricky water to deal with too, because it's going to be third-party application. It's going to be separate from the EHR, and it could have a means to break into cyber attack style. So I don't know. It's kind of it's a great and scary future at the same time. But it's one thing I kind of was thinking about whenever you brought up HIPAA relations and the HIPAA world.
Yeah, and not only related to that is keep an eye also on what states are doing around AI policy, because the feds are moving a little slower. States are not, particularly certain states are not. And depending on how they write that policy, they may be not writing it specific to like telehealth, but it's going to impact them. There was one, and I'm sorry, I can't remember the state right now. There was a state that introduced a bill that said that providers must let their patient be aware if AI is being used when they're providing services, which I think the author was probably thinking like, oh, if like you have like AI like providing like a healthcare service, maybe doing like some sort of intake or something. But AI is like embedded in a lot of like the technology that we use. And it's like, well, is a provider going to know there's like some sort of AI processing in the background on the piece of technology that they're using? And do they need to then let the patient know? It's like they're not providing a healthcare services. It's just like the data processing it's doing in the back end. I'm like, does that mean that you need to like let them know? It's like, I mean, the author, I'm pretty sure was thinking of like, yeah, we don't want them like having AI on there, like interacting with the patient, like unless they're aware of that and everything. It's like, yeah, but the way the bill's written, it has this confusing effect. So,
For sure. For sure.
mhm.
Yeah.
That makes sense.
Yeah. Thank you so much. Yeah, I think Caleb will launch a post polling questions before we sign off. We'll give you a moment to do those. There they are. So please fill those out before leaving us. But if you do have any questions, feel free, just ask those, put them in the chat, email them to us. We'll be happy to get those back to May. She's very responsive and a great resource to have. So we're greatly appreciative of your time today, May. You're educating us and giving us these resources. So we appreciate you.
Okay. All right. Thank you for having me.
All righty. You have a great rest of your day, everyone.